Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today we're going to have two presenters, the first one of those being Torrie Smith, who is a PGY1 resident at OhioHealth, Marion General Hospital, and she will be presenting a journal club on the evaluation of patient outcomes associated with lactated ringers versus normal saline in patients presenting with DKA in a multi-center health system.
Thank you. So my presentation today is titled The Great Fluid Debate, Normal Saline versus Lactated Ringers in DKA Management. Here are the objectives for this presentation. I plan to review literature around fluids in the treatment of DKA, examine a study, and highlight how the findings can be used in the emergency department. Here are abbreviations used in this presentation, most of which you all should be familiar with. So starting with the pathophysiology, a patient may arrive to the ER vomiting, having abdominal pain, or excessive thirst that can be secondary to severe insulin deficiency, infections, insufficient insulin intake. When insulin is deficient, glucose cannot enter the cells. It stays in the blood, causing high blood sugar levels while the cells are starved. This severe deficiency of insulin may lead to an increase of concentrations of counter-regulatory hormones such as glucagon, cortisol, epinephrine, and growth hormones. They produce more glucose to supply energy to the cells. Proteins and lipids are then synthesized into glucose via an increase in gluconeogenesis, and glycogen is synthesized to glucose via glycogenolysis. However, the cells cannot use the glucose, which leads to more sugar in the blood. As these levels exceed the ability of the kidneys to reabsorb, it overflows into urine, taking water and electrolytes along in osmotic diuresis. The results in this large volumes of urine, dehydration, and excessive thirst. Fat is then converted to fatty acids via lipolysis for alternative energy. In the liver, metabolism of fatty acids is an alternative energy source which produces ketone bodies. In summary, the body is using fatty acids as energy instead of glucose, which leads to acid buildup of ketones and can cause hyperglycemia, dehydration, and metabolic acidosis. So the study I'm reviewing today uses the ADA definitions of DKA and DKA resolution from the 2009 guidelines, which have since been updated. So patients in this study, they define DKA as patients presenting with a glucose level greater than 250, an osmolality less than 320, a pH less than or equal to 7.3, a bicarbonate concentration less than or equal to 18, as well as an anion gap greater than 10. Resolution in this study is defined as normalization of glucose in two of the following, including serum bicarbonate greater than or equal to 15, a venous pH greater than 7.3, and a normalized anion gap of less than or equal to 12. The common treatment pathway in DKA is IV fluids, insulin, and potassium. Insulin is used to reduce the glucose level, and potassium replacement is important due to metabolic and electrolyte derangements. However, the focus of this presentation is on IV fluids. The current 2024 guidelines recommend normal saline. However, they do note that recent studies have reported the administration of balanced crystalloids result in faster DKA resolution, shorter hospital length of stay, and less frequent development of hyperchloremic metabolic acidosis. Patients are volume depleted due to the lack of absorption of glucose in the kidneys, which in turn can overflow into the urine and takes the water and electrolytes along in osmotic diuresis, which results in large volumes of urine, dehydration, and excessive thirst. Intravascular volume is restored by expanding plasma volume, increasing preload, and enhancing cardiac output. So increasing tissue and organ perfusion decreases lactate formation. Fluids can also improve renal perfusion and promotes the excretion of glucose and ketone bodies. It's noted that glucose may drop by 50 to 70 milligrams per deciliter per hour with fluid therapy alone. Electrolyte deficits are then corrected by restoring blood volume, optimizing cellular hydration, and using osmosis to shift water into or out of the cell. When it comes to comparing the fluids evaluated in this study, normal saline and lactated ringers, the dose rate for each fluid is the same at 0.5 to 1 liter per hour for 1 to 4 hours. When considering to use normal saline, it is cost-effective and mildly acidic, but considerations include hypernatremia and hyperchloremia due to the increased concentration of sodium and chloride in the fluid composition. Resuscitating patients with fluids high in chloride may lead to decreased renal blood flow, which in turn may cause an AKI. On the other hand, lactated ringers has an alkalizing effect as it is converted into bicarbonate, which raises the blood pH and treats metabolic acidosis. Considerations for using LR includes hypercalcemia and hyperkalemia due to the increased concentration of calcium and potassium electrolytes. A downside to using lactated ringers is that it does not come commercially available with other electrolytes in it, for example, potassium. So if a patient requires more potassium supplementation, the pharmacy would have to compound this medication, and some sites may not have a 24-hour pharmacy. So now I'm going to discuss 2 trials that were completed comparing fluids used in non-critically ill adults and those with DKA. So the SALT ED trial was a single-center, pragmatic, multiple crossover trial that looked at non-critically ill patients. The study included adult patients who received 500 milliliters of balanced crystalloids, such as lactated ringers or plasmolite, with 95% of the patients receiving lactated ringers, or there were patients that received normal saline based on the calendar month. The primary outcome looked at hospital-free days, where secondary outcomes included major adverse kidney events within 30 days. Each group had a median of 25 hospital-free days, but the balanced crystalloids demonstrated a statistically significant lower rate of major adverse kidney events. A limitation to the study was that they looked at non-critically ill patients and fluids were not monitored after admission to the hospital. The RELIANCE DKA study was a retrospective multi-center single health system cohort study that evaluated the time to high anion gap metabolic acidosis resolution using lactated ringers compared to normal saline in patients in the ICU. The mean time to anion gap resolution was statistically significant in the LR group at 14.3 hours, but the overall time to DKA resolution was not. Lactated ringers may have an advantage over normal saline in the management of DKA. However, the study site's definition of DKA resolution was different than the ADA resolution criteria at the time. So more details about the study led to the evaluation of patient outcomes associated with lactated ringers versus normal saline in patients presenting with diabetic ketoacidosis in a multi-center health system. The purpose of this study was to assess the impact of intravenous fluid selection on patient outcomes in DKA. This study was a multi-center observational retrospective IRB-approved study that included 4 community hospital emergency departments in Texas. The cohorts included normal saline from January to August of 2020 and lactated ringers from January to August of 2021. The order set for DKA was changed to LR as the preferred fluid after an increasing favorable amount of data for the use of LR. The study population included adults at orders from the DKA order set, and the study's diagnosis of DKA was consistent with the 2009 ADA clinical guidelines that was discussed earlier in this presentation, which, as a reminder, included an elevated blood glucose and anion gap, as well as a decreased pH, decreased bicarbonate, and decreased osmolality. Patients were excluded from the study if they had hyperchloremia, osmolality greater than 320, and or received 1 liter of the competing fluid. So just over 1,000 patients were screened for eligibility for this trial. You can then see that 723 patients were excluded due to various reasons. Almost 400 patients were excluded because they received more than 1 liter of the competing fluid, and almost 130 patients were excluded due to other reasons that were not mentioned in the exclusion criteria. So this left 362 patients enrolled in the study, with 136 patients in the LR cohort and 226 patients in the NS cohort. And you can see each site was further broken down. The primary outcome was the time to resolution of DKA according to the 2009 guidelines, including a normalization of glucose, a decrease of anion gap, or an increase of bicarb and pH. The time to resolution was calculated by subtracting the date and time of the first lab results meeting the defined DKA criteria from the date and time of the first lab results meeting the DKA resolution. Secondary outcomes included time to discontinuation of insulin infusions, total amount of fluid received, the incidence of hyperchloremia, and the amount of potassium supplementation each patient needed. This slide demonstrates the statistical analyses that were used. Important highlights include an interquartile range, which is the range of the middle half of data to highlight variability and detect outliers. It's also important to note that significance was designated as a p-value of less than 0.05. The number to meet power was never described in this publication, but the authors completed a post hoc analysis to assess power. In the demographics, you can see that age and gender were both statistically significant in both cohorts. I included the races that were a majority, but it is important to note that race alone was not statistically significant. The low number of patients in the LR group that had diabetes documented were likely either not diagnosed yet or this was their first presentation. The overall results, I did outline the primary outcome in red. So the time to the resolution of DKA was statistically significant in the LR group compared to the normal saline group. The authors included length of stay in their secondary results. However, this was not a predefined secondary outcome, and the ICU length of stay was statistically shorter in the normal saline group. Here, I broke down the evaluation of the primary outcome by site level. These results were not statistically significant at this level. This could have been due to low sample sizes at each site, and this was similar in secondary outcomes as well. However, Site 3 had a statistically significant time to discontinuation of insulin infusion in the lactated ringers group, and Site 2 had a statistically significant shorter length of stay in the normal saline group. A subgroup analysis was also completed that analyzed patients with chronic kidney disease, cirrhosis, and congestive heart failure. However, none of these results were statistically significant between the cohorts. The author's conclusions provide evidence that lactated ringers may be preferred over normal saline, reducing the time to DKA resolution. However, larger randomized control trials are needed to confirm these findings and assess broader applicability. In my critique, the strengths of this study is that it offers generalizability by including multiple sites within an institution and evaluated the incidence of hyperchloremia, which other studies had not looked at. However, limitations include the retrospective nature and design and the inability to determine if patients received fluids prior to arrival by EMS. Not determining or categorizing the severity of DKA could have also skewed results, as those with less severe DKA may have resolved faster than others. The authors have highlighted that each site may have different policies regarding the nature of discontinuation of insulin infusions, as some sites may not do that outside of morning interdisciplinary rounds. And the authors also mention similar findings to prior research demonstrating the benefits of balanced crystalloids in critically ill patients in patients with DKA. However, the study did not mention specifically looking at critically ill patients. My overall clinical application, I believe there's room for ample room for discussion regarding the use of LR for DKA management, and smaller sites may not prefer LR due to the lack of premixed formulations with electrolytes. It's also difficult to determine which severity of DKA patients would benefit the most from lactated ringers. And now I will open up the floor to questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.